Welcome, everyone. Thank you for taking the time to be here this evening. I'm Dr. Michael Vogelbaum, Chief of Neurosurgery and Program Leader of Neuro-Oncology at Moffitt Cancer Center. I'm excited to introduce you to my colleagues in just a moment, and I'm confident that you'll find value in the information we will share with you tonight. But before we begin, please be advised, the content that we're going to present tonight is not intended to be medical advice, and viewers should consult their physician if they have any questions. Viewers should not rely on information contained within this presentation or webinar for immediate or urgent clinical needs. Additionally, if you think you may have a medical emergency, please call your physician or go to the nearest emergency department or call 911 immediately. Never disregard professional medical advice or delay seeking care because of information contained in this webinar. Again, we're pleased to have you with us tonight. And before I introduce you to our speakers, I want to remind you that after we hear from our speakers, you'll have the opportunity to have your questions answered by these experts. We invite you to type your questions into the Q&A box located at the bottom of your screen, and we'll be monitoring those and we'll answer them during the Q&A session. Tonight, we're going to focus on one of the deadliest cancers faced by humans, glioblastoma, otherwise known as GBM. While we all sometimes hear wonderful stories from people who think that they've been cured, the sad truth is that there's still no cure for this cancer, and even the very rare individuals who survive more than 5 years from this cancer soon thereafter succumb to it. That said, we as a field do have treatments and new treatments that have helped to improve survival. And the Moffitt Neuro-Oncology Program has the latest tools and therapies delivered by a highly coordinated, multidisciplinary medical team to offer the best possible outcomes for our patients with GBM. We all know, though, that that is not enough, and we need to provide care beyond the standard of care. What makes us different from other medical centers in our region is that we can offer additional treatment options that are so new as to be considered investigational and available only via a clinical trial. Some of these treatments have been developed in coordination with other nationally known cancer centers or by our partners in industry. Others are based upon scientific discoveries made here at Moffitt. In the end, we consider these clinical trials to be an essential part of the comprehensive care of patients with glioblastoma. So tonight you'll hear from 3 of our GBM experts who will discuss some of the most exciting new therapies that have been made available at Moffitt in the form of clinical trials. First, we will hear from Dr. Patrick Grogan. Dr. Grogan trained initially as a medical oncologist and then completed further training in a neuro-oncology fellowship. He now oversees our clinical trial portfolio, and he will discuss some of the recent trials that he has opened at Moffitt. Dr. Grogan.
Dr. Vogelbaum, thank you very much. And everybody, thank you for being on tonight. Real pleasure to have you. I've been tasked with no small task of discussing why clinical trials are important in the management of folks with glioblastoma and other gliomas for that matter. But as Dr. Vogelbaum mentioned, I think the focus really tonight should be on that of glioblastoma. Next slide, please. As Dr. Vogelbaum certainly alluded to, there really remain a lot of challenges in the management of this tumor. And I think the biggest one is simply the fact that this remains a tumor that we don't consider curable. When you look at the best available treatments that are currently accessible to patients, and you look, for example, at the survival curve that I have here on the chart, the prognosis for individuals still ranges between about a year or two, and it's really inadequate, at least in terms of how we feel from a neuro-oncology field. The issue, one of the biggest issues, is that our standard management has been one that really hasn't changed for a prolonged period of time. Radiation has been around for a long time. There have been several toxic chemotherapies around for nearly 5 decades. But beyond that, over the last 2 decades, our advancements have been fairly minor. 2 decades ago, the chemotherapeutic agent temozolomide came about, and in many ways that was revolutionary. But for about 60% of folks with glioblastoma, that treatment option still remains of fairly limited utility. Since that time, we've had the approval of a therapy that doesn't prolong survival, though it does improve quality of life in folks. We've learned more about the molecular genetics of tumors. And so for a very small subset of individuals, less than 3 to 5%, we have the ability to harness certain drugs that target specific mutations. But again, this is in a very small fraction of individuals, unfortunately. And then about 10 years ago came Optune Tumor Treating Fields. It's a device worn on the head that ultimately comes with a fair number of quality of life implications. And while the right therapy for certain folks, we know that 75 to 80% of individuals, both at Moffitt and nationally, choose to take a pass on this simply because of the implications that come with the quality of life of this therapy. Next slide, please. So that, of course, begs the question, why do we need clinical trials? And I think that question in many ways answers itself. But it's certainly not for a lack of trying. Over the last handful of decades, various chemotherapies, immunotherapies, implantable devices, et cetera, have been utilized to try to help folks with these tumors. And you may ask yourself, okay, well, you've tried these things over the last few decades, but really you're telling me that nothing has come about with that. Why continue trying? And I think the answer to that is simply the fact that both in those clinical trials and in the research laboratory, there have been great strides that have been made. We learn from each clinical trial that comes about. We understand why certain patients may derive benefit, but that the trial is negative overall. And certainly from the research labs, both at Moffitt and at other institutions, we have much better understanding of why therapies may be failing. And so, for example, we have better understanding of why the tumor microenvironment, why the brain is so immunosuppressive, and why immunotherapies may not work. We understand the blood-brain barrier better and how to better deliver drugs to actually reach the tumor. We understand the differences amongst different patients with tumors and why those tumors are different. And even within an individual's tumor, those cells that exist can be very different from one location to the next. And so as a result, we've refined our ability to learn from this and better design therapies. And on top of that, over the last handful of decades, and certainly over the last 2 decades, we've gotten better at designing clinical trials. Instead of the futile clinical trials that enroll a lot of patients in therapies that ultimately don't work, we've gotten better at clinical trial design to make these better efficient and no longer throw what effectively become unuseful or therapies at individuals that otherwise would have a shot at other options. And so the theme of this is we've learned a lot to overcome the challenges that we've faced. Next slide, please. At the end of the day, however, really the reason that we do clinical trials is because of something that I stated on the first slide. It's that outcomes for patients with glioblastomas remain entirely unacceptable. 1 to 2 years for the median prognosis is devastating for us as providers, certainly for patients and certainly for families as well. And if you look at the NCCN guidelines, the NCCN being a group that defines national standards for treatment and a group that I'm a part of, what you'll see highlighted here is that at the top of the management for a variety of tumors, including glioblastoma, what's recommended is enrollment in clinical trials simply because of the inadequacy of our standard of care, despite those best efforts. Next slide, please. As a result of that, we at Moffitt, as Dr. Vogelbaum had mentioned, try to employ as many clinical trials as we can, doing so in a safe way and with science that we can stand behind. And so what that means is that we have a variety of clinical trials at any one time that are in a variety of different phases. These could be from exploratory phases to safety phases to truly looking at the efficacy of these drugs and these agents. And at any given time, we have a variety of different options to try to target these tumors. I'm certainly not going to try to steal the thunder of Dr. Liu and Dr. Etame, who come after me, who are going to discuss some really exciting immunocellular therapy that we currently have available. And Dr. Etame speaking on some of the research that he's done out of his lab that's led to a very promising early phase clinical trial. But I'd like to highlight the fact that we certainly have other therapies, small molecule inhibitors, metabolic therapies, immunotherapies, totally independent of the fact that that we use cellular therapy, as Dr. Liu will talk about. Next slide, please. And really, I'd like to share a few of those, at least those that I find the most exciting today. One of the trials is called the GBM Agile trial, and Agile stands for Adaptive Global Innovative Learning Environment. Next slide, please. This is a trial that's available for both patients in the newly diagnosed and the recurrent setting. It's a later phase trial, so it helps we've seen promise in the preclinical setting and in the safety setting. And so ultimately, this is looking to see how well do these drugs actually work in patients with glioblastoma. But really the reason that I'm excited about this trial is that this is what we call an adaptive trial. In contrast to most clinical trials where it opens, it closes, it opens, it closes, somebody may be randomized to standard of care versus getting standard of care plus or minus plus the most exciting new experimental therapy. There's a lot of inefficiency with that, and these clinical trials, again, open and they close. This is a trial that is effectively is constantly open. And so it's constantly bringing in the newest and the most exciting therapies. And when one drug rotates out, another that's on the horizon is able to rotate in. And so in a very efficient way, we're able to clearly assess what these drugs do in a kind of a preliminary manner first. And if they look exciting, they graduate on to a later phase in the study, ultimately allowing access to that exciting drug for other patients. And so it increases our ability to deliver those drugs to patients logistically. It improves resource utility. And most importantly, it doesn't take away from the standard of care that patients are able to receive. We're still able to give radiation and chemo, but we're trying to really add that frosting on the cake, so to speak, that may be the breakthrough. Next slide, please. I'd like to share with you today a couple of the drugs that are currently available on that trial. There have been a handful in the past, but those that are currently available include a drug called tririzolol. This is an oral drug that helps to decrease glutamate signaling within glioblastoma cells in the microenvironment. Now, why is that important? Well, in recent years, what's been shown is that glutamate signaling really causes these glioblastoma tumors to grow, to proliferate, to survive, and certainly to invade into normal tissue. And so as a result, the idea is that if we can disrupt glutamate signaling, we ultimately disrupt this proliferative pathway of these tumor cells and thereby keep the glioblastoma in check for a longer period of time, potentially even killing it as well. So this has been particularly exciting in terms of some of the preclinical data that's been generated and the promise that's been shown. Next slide, please. This next slide is showing a drug that I'm actually really excited about. It's a drug called VT1021. Doesn't even have a name yet. This is an infused drug. It's a peptide or protein that ultimately upregulates a molecule called TSC1. And as you can tell here, I could certainly get into the weeds about what this does, but very briefly, this is a bifunctional molecule that both kills a tumor cell when it comes into contact with it, while also killing some of the vasculature that feed the tumor with oxygen and nutrients. And on top of that, we know that the brain is a very suppressive microenvironment for the immune system, meaning the immune system can't attack the tumor the way that it does in other types of tumors. And one of the things that this drug does is it suppresses that suppressive component. It takes that away and thereby helps to facilitate an improved immune response. One of the reasons that I'm excited about this is that in an early phase recurrent study that was done, 50% of patients with recurrent glioblastoma had disease control, which is a really high number in that setting. And there were even 3 complete responses, meaning on the MRI, the tumor completely went away. And so that's really in many ways unheard of in this setting. Next slide, please. The last drug is something called ADI-PEG20. It's actually quite simple. This is a metabolic therapy that takes advantage of the fact that about a third of glioblastoma lack the ability to produce an amino acid for protein production called arginine. So the idea is if you can deplete that level of arginine within a person's system, ultimately these are tumors that are no longer able to utilize that to grow, to divide, and to survive. Next slide, please. Finally, I'd like to talk about one other study called the NRG-BN010 study. It's got a big long name, and I'll explain it in detail. Next slide, please. This is a study that Moffitt was involved in the early phase setting, one of 5 sites nationally, that ultimately has led to the development of a phase 2 efficacy and safety study that looks at treatment of recurrent glioblastoma and now is open nationally. This is a study that is able to utilize patients, is able to take patients who are eligible for surgery in the recurrent setting and those who aren't eligible, and combine both radiation with an exciting immunotherapeutic combination. Next slide, please. Now, I told you that immunotherapy typically doesn't work well in glioblastoma, and this is something that helps to try to circumvent that and overcome that. One of the reasons that immunotherapy doesn't work is that these tumor cells don't look particularly wonky. They're not mutated by tobacco smoke like lung cancer or UV rays like melanoma. And so ultimately, they don't have a high mutational burden. They don't look weird to the immune system. And in addition, I mentioned that the brain itself is fair paucity of immune cells to ultimately mount an anti-tumor attack. So what the idea of this is you combine a drug called atezolizumab that takes the brake off of the activating component of the the immune system, in combination with tocilizumab, which again is one of those drugs that suppresses that suppressive component of the microenvironment. So you're essentially adding gas to the fire, and you're taking the fire truck away, and ultimately mounting a far more prolific immune response, which we've seen some very interesting responses in the early phase. We combine this with radiation, not only to attack the tumor, but to stimulate release of proteins that serves as a vaccine within the brain. And as you can see on the side of the screen here, we see that combination of the therapy in animal studies works far better than individual therapies alone, keeping mice alive for a prolonged period of time and curing some of those mice of the glioblastoma. So next slide. With that being said, I'd like to, again, thank you for being here tonight. I'd like to thank Dr. Vogelbaum for the opportunity to talk and certainly pass it back to you.
Great. Thank you, Dr. Grogan, and really exciting new trials. I think that we've been expanding our portfolio of trials under Dr. Grogan's leadership, and we'll be able to address questions later on in this presentation. Next, we're going to hear from Dr. Arnold Etame. Dr. Etame is a board-certified neurosurgeon who specializes in the care of patients with brain cancer. He's also a glioma scientist who has a laboratory that is dedicated to unraveling the mechanisms underlying the growth of GBM in order to discover new targets to attack. Dr. Etame has recently received one of the largest research grants available from the National Institutes of Health, or NIH. And so now we have 2 R01 funded neurosurgeons in our department, which is a remarkable feat in itself, as very few neurosurgeons nationally are able to achieve this level of funding. Dr. Etame is going to talk about his laboratory research and how he is in the process of translating it into an exciting new clinical trial. Dr. Etame.
Thank you very much, Dr. Vogelbaum, and thank you all for joining us in this webinar. I will be talking about some research that we've done on glioblastoma and how that research we are able to translate it into an early phase clinical trial, which eventually we will advance. As Dr. Vogelbaum and Dr. Grogan have already alluded to, the outcomes for glioblastoma is not acceptable. And that is what motivates us every day to work hard to find a cure for this tumor or a better way to control the disease so patients can have meaningful survival. Glioblastoma is the most common primary brain tumor. It's highly resistant and it's lethal. The median survival, as Dr. Grogan and Dr. Vogelbaum have alluded to, based on clinical trials and what is commonly encountered, is somewhere between 1 to 2 years. Next slide, please. The challenge with this tumor is that when we get an MRI scan, like you see in this picture, you see the main tumor, but there are tumor cells far away from where the original tumor is located. And so typically what we're looking at on the MRI is the tip of the iceberg. When we do surgery, we're removing this aspect of the tumor, which is white here that lights up with contrast. But there are tumor stem cells in the surrounding brain, which over time can develop into their own tumors and cause problems for the patient because they become very resistant and we don't really have good therapies. This is an autopsy specimen here with a temporal glioma. This would be what will be the primary tumor site. But you can see all these red stains even on the other side of the brain, showing that there's tumor infiltration or tumor invasion into the white matter of the brain extensively. And so it creates a challenge for us surgically because we cannot remove the tumor entirely. And for radiation, it also creates a challenge because sometimes we can just radiate the brain extensively and these cells are already resistant. And then for chemotherapy, the blood-brain barrier can become an impediment. Next slide, please. As this has already been mentioned, this is what our current therapy is. We give radiation and Termida, and then we followed by adjuvant. And based on clinical trials and what we can accomplish, we're looking at a 1 to 2 year survival. Next slide, please. there are things that have been tried in glioblastoma. So as alluded to, temozolomide was the agent that in combination with radiation gave that survival that made it the standard of care. And so there have been attempts to increase the levels of temozolomide to have more availability of temozolomide into the brain, as well as have more temozolomide that can, in these tumors, there's an enzyme called MGMT, which reverses the action of temozolomide. And so if you have more temozolomide, you could potentially overcome that. But the clinical trials did not really pan out. And then there have been vaccine trials where they've targeted unique expressing proteins on the surface of glioblastoma, the EGFR-V3. And that particular trial also, even though there were promising results in early phase trials 1 and 2, the phase 3 trial was actually did not show any increase in survival. And then there is the immune checkpoint inhibitors that also have been tried in glioblastoma, and those trials have failed to meet their primary endpoint. Next slide, please. So what really drives this tumor? As I mentioned before, we see the tip of the iceberg. The brain is filled with glioblastoma stem cells that have traveled far away from the primary tumor. These stem cells are very resistant, and the stem cells have the ability of each developing into a new tumor. They are brain invasive. Not all stem cells are equal. So there are some stem cells that are very aggressive and some that are less aggressive. So I'll refer to the less aggressive stem cells as the good stem cells in quote, the more aggressive stem cells as the evil stem cells. So one thing that one could consider, and what we've considered from a research standpoint, is if you can try to modulate the evolution of these stem cells so they can move more towards the less aggressive type and away from the most aggressive type. And that can significantly, improve survival in these tumors. Next slide, please. Now, what is it about these stem cells? So these stem cells express certain genes, make certain proteins that kind of govern their behavior. And so I call this the molecular personality of GBM stem cells. They're very colorful, but the big picture here, and to put it in very straightforward language, is that stem cells that express genes and proteins that we would classify as proneural will fall under the less aggressive stem cells. So that would be the good stem cells. And then the mesenchymal, which is actually extremely aggressive, very resistant to therapy, would be the evil. So the point I made in the last slide is within a tumor, if one could find therapies that could drive the tumor cells, their gene expression more towards a proneural, you could significantly improve survival. Next slide, please. What's interesting is that even within the same tumor, you have good and evil stem cells like coexisting. As you can imagine, the good stem cells would be more responsive to therapy. The evil stem cells would stick around and become resistant, more aggressive, and that's what is going to cause problems for the patient. In this picture that you see here, there is a brain tumor. This is a glioblastoma here. And blue stands for proneural, the good stem cell. Green stands for mesenchymal. So when surgeons biopsied different regions of this same tumor, they found out that there were several areas that had gene expression that was consistent with what I'll call the good stem cell, and then there was an area of the bad stem cell. So even within the same tumor, there is, and Dr. Grogan mentioned about the tumor being heterogeneous, being made of different cell types. Next slide, please. This is a nice study that really addresses the question of if within the same tumor, you have these different cell type, stem cell type population, what happens if you take a good stem cell, which is the black line, that's the proneural, if you were to contaminate, or let's say the signature, something happened to it where it was forced to change its gene expression towards these other types, most notably the mesenchymal, what happens to the survival? And you can see here that the long-term survival is highly favored in tumors that are purely proneural or highly proneural, which is a good type. But anytime that signature is contaminated, this survival significantly declines. And so in a glioblastoma tumor, you have these good and bad stem cells, and it's always the equilibrium or the battle between those two. And unfortunately, some of the therapies tend to drive these stem cells towards, sometimes as they become resistant, they become much more head towards the mesenchymal. Next slide, please. So based on that premise of trying to see how we can modulate stem cells to be less aggressive, we developed a therapeutic program where basically we looked at what are the different aspects that drive this malignant behavior, where if you have stem cells that are less aggressive, they'll become more aggressive, more resistant, and then cause problems. So there's the mesenchymal reprogramming, which is one way of making the stem cells very aggressive. There's epigenetics, which also it's another way. And then there's hypoxia, which is basically as these tumors grow, they have regions where there's less oxygen, less nutrients, and the stem cells there are highly adaptive and they'll become very resistant to therapy. Along these three aspects, we have developed anything here that's preclinical means that the studies are still more animal studies and not yet up at the clinical trial phase. But the mesenchymal reprogramming, there's an early clinical trial that I will talk about. So malignant reprogramming, very, very important, and it's inevitable because as Dr. Vogelbaum alluded, even when patients make it up to 5 years, these tumors would come back and be much more aggressive, and then our therapies will not work. So we need to develop clinical trials that really focus on this aspect of the tumor, and that's what we need in order to advance, outcomes. Next slide, please. As I said, what we did was to start with preclinical studies and then present these for reviews by the NIH, experts at the NIH, where expert panels can look at the science and decide that, well, we think that this is an innovative idea that can really improve outcomes. So we currently have 3 different NIH fundings, which are centered on targeting glioblastoma stem cells. But one of them, as I mentioned, the mesenchymal reprogramming, we now have a clinical trial. Next slide, please. So I'll talk about my first clinical trial based on the science of going after the glioblastoma stem cells. In the interest of time, this particular agent, xevinapant, targets a pathway which some of those grants uncovered and were part of the grants that is responsible for making glioblastoma stem cells much more resistant. The drug also has the ability of reversing what I showed before, the proneural, which is the less aggressive subtype. I showed that sometimes it wants to move towards the aggressive subtype. So basically, the drug is very effective in reversing that process. This clinical trial is a window of opportunity trial where patients would have, these are patients that have recurrent glioblastoma. They will have the drug for a few days and then we'll do surgery and then they'll continue the drug. We'll take the surgery tissue and look at the tissue to make sure that the drug is penetrating into the tumor, and within this tumor, it is exerting its effect. Based on this early trial, if we can establish that there's very good penetrance into the tumor, then we'll move into the next trial. And of note, this agent synergizes well with radiation and chemotherapy, so it can be combined with both. Next slide, please. So some final thoughts to leave you with. Strategies to try to find a cure for GBM have not been successful under the current paradigm. And the issues have been mainly the stem cells that are highly aggressive. Our approach really, it's a paradigm shift where we are trying to exploit this transition between where stem cells can go from good to bad and really change their trajectory during treatment more towards the good subtype so we can prolong survival for patients. I would like to thank you all for, again, participating in this webinar, and thanks immensely, Dr. Vogelbaum, for organizing this and for doing this for our patients.
Well, thank you, Dr. Etame. It's really inspirational what you've been doing. It really shows the true power of the combined scientific abilities here at Moffitt, as well as our ability to treat patients and launch innovative new clinical trials for our patients. That's really what our mission is all about. And that's why we have folks who do both science and care for patients at Moffitt. Before we move on, I just want to remind everyone that we do have the question and answer session at the end. You can go ahead and start entering questions now along the way as they come up, and we'll be able to see them and start to address them once we get to the end. Next, we're going to hear from Dr. James Liu. Dr. Liu is also a board-certified neurosurgeon who performs both cranial and spinal neurosurgery for patients with cancers that arise from the brain or that spread to it. One area of expertise that he's developed is to lead clinical trials that involve a neurosurgical component. Tonight, he'll discuss an exciting new immunotherapy trial that involves the use of immune cells that are primed to attack GBM tumor cells. Dr. Liu.
Thank you, Dr. Vogelbaum. Good evening, everybody. It's a pleasure to be here. Thank you for your attention. So today I'm going to talk a little bit about cellular immunotherapies for glioblastoma. In particular, a very exciting clinical trial that we opened up here earlier in the year. But to start out, first, I wanted to talk a little bit about what is cellular immunotherapy. What does that actually mean? In essence, it means utilizing the immune system to actively detect and eliminate tumor cells. But when we think about cellular immunotherapies, there's a lot of different components. And you can see here, the names are so important as that the idea is that there are many different ways to kickstart and activate the body's innate immune system to try to fight foreign objects, and particularly cancer cells. The bottom three therapies, the strategies, checkpoint inhibitors, vaccine therapies, adaptive immunity have been used in glioblastoma. In particular, we're going to talk a little bit about adaptive immunity a little bit later. So when we talk about cellular immunotherapy for GBMs, I think it's important to think about why are there challenges when it comes to immunotherapy. Immunotherapy has become very popular for certain cancers and have achieved very, very good results. But as Dr. Grogan mentioned earlier, glioblastoma is unique from a lot of different cancers because it induces a very significant complex systemic and intratumoral immunosuppression that have prevented previous immunotherapy strategies from being very effective. There have been several strategies of immunotherapy that have been attempted on glioblastomas. One of them is immune checkpoint inhibitors, which is a way of trying to deactivate the tumor's natural ability to decrease the immune system. And these have shown mixed results in improving survival in GBM patients. But one of the drawbacks is that there has been very high toxicities. Oncolytic viruses are something that's in the media quite a bit. You may have heard about and are currently being studied. And these utilize immunotherapy by infecting tumor cells to activate the body's innate immune system. Many studies are currently underway, but the results are mixed with some promising results. And finally, chimeric antigen receptor T cells, which you may have heard about in the hematologic malignancies, they have been applied to glioblastoma as well. They've shown some promise in recurrent GBMs, but they are limited due to the cell specificity that's required for these. CAR T cells need to target very specific targets on tumor cells. And one of the problems with glioblastoma, as Dr. Grogan mentioned, is that the cells are all very, very different. And so when you have a CAR T cell that only wants to target a certain type of receptor or a certain type of cell, they can become less effective. So when we think about what's left in the immunotherapy and immune response, we can kind of break it down into two main categories. On the left side of the sphere, you have the innate immunity. That's the rapid response, non-specific part of our immune system. On the right side is the adaptive immunity. That's the slower response, but more specific and more lethal. You can see here on the right side, those are where the T cells and the B cells are. And the CAR T cells are the T cells that are where the T cells come from. But because we talked about the toxicities in the T cells, we want to find something that's in between the innate immunity as well as the adaptive immunity. And that's why in the middle here, where the red circle is the gamma delta T cell. There have been some interest in gamma delta T cells because of a few reasons. One, they're like T cells in the adaptive immunity, like used in the CAR T cells, but they don't quite have the toxicity that T cells do. But they also have the safety, recognition, and killing abilities of natural killer cells, which are found on the left side of the sphere in the innate immunity, with better durability than natural killer cells. In addition, gamma delta T cells are also able to recognize healthy from tumor cells, which is very important in any kind of cancer therapy. Next slide. So a company called Innate Bio wanted to focus on the use of gamma delta T cells and started a trial. And the trial that we are starting with them is called a phase 2 drug-resistant immunotherapy with activated gene-modified autologous gamma delta T cells in combination with maintenance temozolomide in subjects with newly diagnosed glioblastoma. This is a trial meant to be started in 12 centers. We were the third center to be started, and there are 6 current centers open that are enrolling patients. The idea of this trial is that it uses gamma delta T cells in conjunction with temozolomide, which is currently the first-line medical therapy standard of care. The reason it works well with temozolomide is that temozolomide induces DNA damage response ligands to be expressed on the tumor cells. Gamma delta T cells can recognize and attack these ligands on tumor cells. In addition, gamma delta T cells can be modified to resist chemotherapy so that they can be administered with temozolomide to allow for a synergistic effect in destroying the tumor cells. There was a phase 1 study performed at the University of Alabama, Birmingham, in which 10 patients were treated, and there were no toxicities related to gamma delta T cells, which is one of the main concerns in CAR T cells. So an advantage in that regard. This study is specifically meant for newly diagnosed, treatment-naive IDH wild-type glioblastoma. I think that's important to note because there are very few relative newly diagnosed glioblastoma clinical trials because the standard of care is very clear for first-line treatment. Most treatments are for recurrent tumors, and this is very exciting that this is for a newly diagnosed clinical trial. So to walk through what the trial looks like, we'll go to the next slide. This is how typically glioblastoma diagnosis and treatment goes. A patient presents with neurological dysfunction, and the diagnosis is made based on MRI. The first step in the standard of care is undergoing surgery. But in the trial, in addition to undergoing surgery, a catheter is placed into the tumor cavity. While the patient is recovering from surgery, apheresis is performed to obtain the patient's own T cells. Next, radiation and chemotherapy is performed as per standard protocol in the standard of care. While radiation and chemotherapy are being performed, you can see on the bottom left here, the T cells that were collected during apheresis are sent to the sponsor. They're modified to resist chemotherapy and also expanded to be delivered back into the patient. On the bottom right, after the patient receives the standard radiation and concurrent chemotherapy, while the patient is obtaining maintenance chemotherapy, the T cells are injected through the catheter into the tumor site. So the beauty of this trial is that the standard of care is completely followed. There's no delay in surgery or the concurrent chemoradiation therapy or the maintenance therapy. The trial is only in addition to the standard of care that is being applied by obtaining the T cells through apheresis while the patient is recovering from surgery and administering the gamma delta T cells in addition to the maintenance therapy. And so there's no loss of the advantages of the standard of care. Next slide, please. So in summary, this is a trial that we started in January. We've enrolled a few patients. There have been a few patients enrolled in the entire study. The idea is to enroll 40 patients. The primary endpoint is to evaluate whether it affects the 12-month overall survival rate. Secondary endpoints include looking at a variety of adverse events to see how the T cells, the gamma delta T cells, may affect the systemic functioning, as well as other progression markers. Currently in the works with the sponsor are phase 1b and 2 trials with allogeneic gamma delta T cells, and this is T cells from another patient. The current study is using T cells from the patient themselves. But one of the concerns with obtaining T cells from a patient with glioblastoma is that a patient with glioblastoma already has an depressed immune system, and so the T cell count is very low. So additional trials are in works where a donor can provide T cells that may be more healthy to be administered. And also additional trials are being formed for the recurrent glioblastoma setting. Thank you.
Well, thank you, Dr. Liu. That's really an exciting trial, and it starts to put our footprint into the cellular immunotherapy space that has really been remarkable for Moffitt as a whole. I think many people who are watching have heard about many of the great advances made here with cellular immunotherapy, things like CAR T or TIL therapy. We're now expanding our own ability to do that, and Dr. Liu is helping to lead that charge. So at this time, I want to take a moment to introduce one of our partners here at Moffitt, Tyler Wilson. Tyler is with the Moffitt Foundation, and he partners with the Neuro-Oncology Program to ensure that we receive the research dollars we need to get clinical research off the ground and make advances in cancer treatments. If you'd like to learn more about how you can help, please contact Tyler to find out more. Tyler, would you like to say a few words?
Thank you, Dr. Vogelbaum, and thank you so much for the opportunity to be part of this webinar tonight. It's been extremely informative, and the information shared, I think, is displays the tremendous work that's happening across the Neuro-Oncology Department here at Moffitt. I won't take too much time. I know we've got to get to the Q&A, but philanthropy plays such a huge role in all of the initiatives that we've seen here today, providing an impact in a cumulative way to support all of those grants and clinical trials that we have here today. Philanthropy really provides the opportunities for those novel initiatives to move forward. And it's with the support of all of our partners that some of these opportunities have been made possible. To designate a gift specifically to neuro-oncology, it's very simple to do that. If you're making a gift, you can simply note on the memo line of the check, Neuro-Oncology Research, and that gift will be designated towards this department, and then the cumulative impact can be determined by Dr. Vogelbaum and the other leaders within the department towards the area of greatest need. And it really does make a difference in every initiative that we have here at Moffitt. And if you have any questions about philanthropy or would like to learn more when you're ready, my contact information is on the screen. I'd be more than happy to talk with everybody on the call today. So thank you so much.
Well, thank you, Tyler. We appreciate all that philanthropy does to help make this research possible. In fact, that's one reason we're doing this webinar tonight. I really want to emphasize that point. While we've had increasing success in obtaining large research grants from national institutions like NIH and the National Cancer Institute, those grants are never given to fund early stage research where new ideas are being explored. We have to show evidence that these ideas make sense and that they're going to be productive before we can even apply for federal funding. And that funding is usually for more than $1 million, but we have to show that the idea is worth that. One of the only mechanisms we as a field have to fund early stage research is via Philanthropy. With the development of a GBM pilot grant fund, which can be funded by multiple donors, so lots of gifts can help to support this kind of a fund, we can then award pilot grants of 50,000 to 100,000, and yes, that's what it takes to get a new idea off the ground, to our brain tumor scientists and clinical scientists in order for them to develop new ways to explore the biology of GBM or to attack it. We actually have a great cadre of scientists here who are very interested in trying to develop better ways to treat GBM. We just need to help them. And Tyler can help you understand ways in which you can support the development of these types of pilot grants. Okay, now we'll get to the questions, and I'm going to start addressing some of the questions that have come across. So if everyone wants to turn on their camera, and I'll start with the question that I think, Dr. Grogan, you may be the best to answer this since you have the broadest view of the trials, and that is, how can I find out if I'm eligible for clinical trials like the ones that you've mentioned? And maybe you can also address the question of why is it sometimes hard to get on a clinical trial?
Yeah, it's a great question, or a couple of great questions. I think first and foremost, the easiest thing if you're interested in a clinical trial is simply to reach out. I think obviously if we don't know about you, then it's difficult to help. We certainly have a website at Moffitt that you can visit, but admittedly, these clinical trials have some intricacies to understanding, what are things that you need to have in order to be eligible. Is there something specific to the tumor? Is there something specific to your blood count? Something specific to your condition? A variety of things. And we're always happy to look at that. So if you have a provider who you're already seeing at Moffitt, it could be as simple as asking to talk to them about it. It's certainly something that if you are interested, reaching out to any of us at any time here at Moffitt, we're happy to vet that to see if it's something that you qualify for. And then we have a great team of clinical trial coordinators as well. And these are folks whose job it is to support us with these clinical trials and making sure that people are successfully able to get on those trials. And so those are folks who can screen your situation and help us better understand whether those clinical trials are certainly options for you. And then I'm sorry, Dr. Vogelbaum, what was the second part of that question?
Well, it's really the question of why is it sometimes hard to get onto a clinical trial? Why are some of the eligibility criteria restrictive?
Yeah, and that's a really good question too, because admittedly, I think we all find that frustrating, both as patients, certainly as patients, as families, and us as providers as well. But it's also important to recognize that these are clinical trials that have very specific eligibility criteria, in part because they're looking at very specific things. And some of these things are such that, for example, on an immune clinical trial, if somebody's immune system is not robust enough to able to generate an immune response, then in a situation like that, it may not be the right clinical trial for someone. We also want to make sure that any therapy that we're doing, we're not hurting someone in the process of treating them. And so there are certain components. So for example, if somebody has an autoimmune condition, revving up somebody's immune system with an immunotherapy may not be the most appropriate therapy. And so a lot of this depends on what's available at the right time for the right person. And unfortunately, there are certainly restrictions. And admittedly, some of those restrictions are indeed frustrating. There's no doubt about it. But it's all done in the best interest to try to not hurt people, and certainly to make sure that we understand whether a therapy actually works at the end of the day or not.
So there was another question about, would you share with us about the side effects on these trials? But I think that's what Dr. Grogan was alluding to, is that each one of the trials has its own profile in terms of risks. And so it really requires a conversation about each specific trial with one of our team members to understand what the risks are in general for the trial, but what the risks are for any given patient. And that's really a office-based kind of conversation that needs to occur for each of those trials. So perhaps Dr. Etame, you can address a question that is surgery always the most common first step with glioblastoma?
Yeah, thank you very much, Dr. Vogelbaum, and thanks also for the question. Yes, so we usually offer surgery as a first step, first for tissue diagnosis, as well as there are lots of data that seems to suggest that the extent of resection how much of the tumor you remove has an impact on survival. And so most patients with the disease, and sometimes surgery is offered because a patient comes in with significant neurological symptoms. So surgery is the most common first step, unless the tumor is in an area where the risk of surgery significantly outweigh the benefits and patients are going to get deficits.
So, Dr. Etame, can you talk about how you've been able to leverage the work you do in the OR to learn from the tumor tissue in the laboratory?
Absolutely. So as I mentioned, I talked about the stem cells. I talked about how you have good stem cells, bad stem cells. And there are certain factors that make the stem cells very aggressive. I talked about the hypoxic, or the areas of the tumor where there's not enough oxygen. So typically, in order to study these tumors in the lab, when we take out tumors from patients with their consent, some of that tumor tissue goes to the lab, and we're able to isolate the stem cell population. And we have the technology to isolate stem cell populations from different regions of the brain. And so that can give us some insight into how stem cells in different regions, evolve, how they respond differentially to therapy.
Thank you. That's wonderful. And really, we don't do surgery just to get tissue to go to the laboratory. Surgery itself has been shown to have an impact on survival. The more we can take out, the longer patients survive. But it actually also provides us with materials that in the end lead to the exciting discoveries that underlie the research that you've been hearing about. Dr. Liu, how does the immune privilege of the brain lead to the decision to select delta T cells as the effector cell of choice for immunotherapy for these tumors?
Yeah, so I think that's a great question. There's a lot of different ways to activate the immune therapy in the cellular immunotherapy strategies. And I think where the gamma delta T cells advantage lie is that they kind of straddle between the innate and the adoptive immune therapies. The adoptive immune therapies, one example is the CAR T cells. One of the difficulties with them, and particularly for GBM and for other cancers in general, is they're very toxic. But we need some kind of specificity in targeting cells. You can't have the innate immunity is too non-specific, and so we want the specificity of the T cells, but not the toxicity of the T cells. And so the gamma delta T cells kind of lie in between the two. Another one of the disadvantages of CAR T cells is that they're very specific in targeting certain ligands, certain receptors that are present on the tumor cells. And so the gamma delta T cells are a little bit less specific in that sense, but still target all tumor cells. And so they can be utilized in this instance. And so that's why one of the reasons that we focused on, or the sponsors focused on this clinical trial using gamma delta T cells. I think there still could be other possibilities using CAR T cells and other T cells, but I think it's useful to use different strategies at the same time in parallel to see which one has the best outcome.
How about TIL therapy? That's really been exciting here at Moffitt. Any thoughts about whether or not TIL therapy could apply?
I think they could apply also. I think there are different ways of attacking the tumor cells. I think one of the difficulties is the heterogeneity, or how many different types of cells actually make up a glioblastoma cell. And that's one of the challenges, the unique challenges of glioblastoma. When you have a tumor that has so many different types of cells and you kill one type of cell, another type of cell can take over. And so certainly the TIL therapy is another way to utilize the immune system, and I think it could be promising.
Yeah, and I think you also addressed the question in your talk about the recovery period after gamma delta T cell immunotherapy. It's really there's no recovery to speak of. It's really the usual recovery from surgery, the radiation, chemotherapy, and then the actual immunotherapy starts during the second phase of chemotherapy. But that's just an outpatient injection of the T cells, and there's really no change in the treatment other than that. Correct?
Yeah, that's correct. So I think one of the beauties of this particular trial is two things that make it very attractive. One is the decrease in toxicity that's inherent to the gamma delta T cells, unlike other types of immunotherapy. The other is that, as I mentioned, during the surgery, we put a catheter into where the tumor was in the brain. So unlike giving the therapy through an IV where it goes through the entire system, the gamma delta T cells are injected directly into the tumor. So it infiltrates into the tumor. It doesn't have to cross a blood-brain barrier. It doesn't go through the whole system and put the patient at a risk for toxicities. And so that's why it's another advantage of this particular therapy is to deliver the additional therapy straight to the tumor site.
Thank you, Dr. Liu. So, Dr. Grogan, you mentioned the NRG trial, and there's a question here about what partner hospitals and centers are you working with on these projects, any in the Northeast? Can you comment on how we partner with others in the field to develop and then introduce these therapies for patients?
Yeah, I think that's an excellent question. And, I would say that neuro-oncology in general is not an enormous field. Brain tumors are certainly underrepresented in terms of oncologists and surgeons and what have you that are involved in the field. It's a smaller field. And so as a result, we get to know each other in the field pretty well. So we have partners up at Dana-Farber, for example. We have partners up at the University of Pennsylvania. And on top of that, we see these people not infrequently at a variety of meetings, and that's where a trial like the NRG trial is born, out of a cooperative group that Dr. Vogelbaum is actually a founding member of. And so these are groups where experts like Dr. Vogelbaum get together, discuss some of the latest and the greatest in terms of scientific ideas coming out of the laboratory and potentially from the setting of early phase trials and put together designs for these trials that ultimately teams can collaborate with. And so all to say that there are participants, for example, in that NRG trial up in the Northeast. And part of that is simply because we're a collaborative group of folks that talk together. As Dr. Liu has talked about, certainly there are trials through which other sponsors exist. That can include industry. That's more of a centralized process run through a company. And less so in terms of talking back and forth with our colleagues. But that's really where those cooperative groups exist, NRG, Alliance, ECOG, et cetera, where we talk with our colleagues to design these trials and make sure that these trials aren't just available to folks here at Moffitt, but that they're available elsewhere. And I think that's important because somebody at Dana-Farber, somebody at UPenn may come up with an exciting technology that we'd like to utilize here and vice versa. We come up with exciting things and exciting ideas. And in order to get those clinical trials to patients and to make sure that access exists, making sure that multiple institutions have those trials available ultimately is paramount to the success and the accrual of those trials and helping folks out in the process.
Well, thank you, Dr. Grogan. And one final question here. One of the attendees says that in Parkinson's disease, MRI-guided ultrasound can remove some tau tangles. Would it help GBM? That's a great question, because that technology that's behind it is one that we're in the process of introducing at Moffitt. The reality is what that technology does is it opens up the barrier that prevents therapeutics from getting into the brain, and it allows them to get in a very targeted way, very focused way. So that's something that we want to introduce for glioblastoma. It's called MR-guided focused ultrasound, and there's a way to use it not to cause tissue damage, but to actually open the blood-brain barrier. And then one can think about doing things like a liquid biopsy to detect tumor, but more importantly, to introduce therapeutics into the brain so that they can get in there more effectively. And that's something that we are very much interested in developing, and hopefully we'll have that up and going this fall. So I see that we're reaching the end of the hour. And so I would like to thank everyone for joining us. I'd like to thank my colleagues, both in the Department of Neuro-Oncology and in the foundation, for helping to organize and present at this webinar. And we appreciate your continued support as we work to revolutionize cancer care and provide the best possible outcomes for our patients. Thank you and good night.